Thank you for Dr. Lynch and the Cancer Center for inviting me to present some of our research work here today on the use of Clostridium perfringens enterotoxin as a potential novel therapy for chemotherapy-resistant ovarian cancer. And I have no conflict of interest. So let me start with some background information about ovarian cancer. Ovarian cancer remains the big killer in the gynecologic oncology specialty, with more than 21,000 new cases and close to 15,000 deaths. And this is mainly related to the fact that most of our patients, because of the lack of an effective screening program, are diagnosed with late-stage disease, so stage 3 and stage 4 disease, about 2/3 of them, when the disease has already spread in the abdominal cavity. And also, many of these patients with disseminated tumor initially respond to the standard combination of surgery followed by adjuvant chemotherapy. Nearly 90% of these patients with advanced disease later on develop recurrent disease and die for chemotherapy-resistant disease. That is why the development of effective therapy, specifically against chemotherapy-resistant tumor, remain, of course, an unmet medical need when we deal with ovarian cancer. Now, in the last few years, my group, as well as several others, tried to use global gene expression profiling analysis in ovarian cancer with the ultimate goal to identify novel candidate tumor markers for using for the diagnosis and therapy of this disease. And my laboratory has used the Affimetric platform, and in particular, the most comprehensive gene chip available right now, so the U133 plus 2A RA chip, to try again to analyze the gene expression profiling, the genetic fingerprint of chemotherapy-resistant tumor. Now, the goal was, of course, to use RNA extracted from extremely purified tumor specimen, and look to again to the gene highly differentially expressed in this tumor. And in this specific, the first pilot group of experiments that I'm going to show you, we compare immediately to such gene expression profiling to the one of normal ovarian epithelial cell that are, again, the tissue of origin of ovarian carcinoma. And so in this first experiment, we try really to use primary culture cell line from a specific histologic type, so the serous papillary, that is the most common histologic type of ovarian carcinoma. And what we've done in that, in those experiments, was again, we developed primary cell line, extremely pure primary cell line of serous papillary carcinoma. And when I say extremely pure, meaning we're trying to really get rid of the stromal cell, the fibroblasts, the tumor-infiltrated lymphocytes, macrophages that we know that infiltrate this disease, to be able to extract RNA from really pure ovarian carcinoma cell. And what we found is in this pilot work was that in using unsupervised cluster analysis, all the 10 ovarian serous papillary ovarian carcinoma, they were able to cluster, as you can see here on the right side, and on the left side, all the normal ovary genetic fingerprint look quite different, therefore was clustering different from the other one. But more importantly, when we look to the gene highly differentially expressed, we found about 125 probe sets that they were highly differentially expressed, at least 5-fold higher in the tumor when compared to the normal ovarian tissue. And this is to show you, in this table, I'm showing the top 15 genes find upregulated in ovarian cancer when compared to normal ovarian epithelial cell. And what we found were these two genes, Claudin 4 and Claudin 3, as a top second and third gene highly differentially expressed. And that was, again, of interest to us, as I'm going to show you in the next few slides. But the point is that we were not really sure if this was an artifact, because, of course, when you're trying to purify primary cell line, you put them in culture. There are some genes that they, of course, they can down-regulate, some other genes they can up-regulate. So we've done, after this pilot work, a confirmatory analysis looking to a different set of 19 serous papillary ovarian carcinoma that in this case were flesh frozen tissue with more than 75% purity when analyzed, again, on the slide. And we compare, once again, the gene expression profiling of those tumors with the one of 15 normal ovarian epithelial cell RNA. And what we found was, once again, the Claudin 3 and Claudin 4 were still at top differentially expressed gene. Once again, confirming that both in primary cell line as well as in fresh fluorescent tissue, Claudin 3 and Claudin 4 are really major players in ovarian carcinoma. Now, what are Claudin 3 and Claudin 4? Claudin 3 and Claudin 4 are tight junction proteins. And as I'm showing in this slide, they are characterized by 4 transmembrane domain and 2 extracellular loop, where one again is higher, is larger than the second one, and the carboxy, and they have also a short carboxy intracellular tail. Now, what is the function in normal tissue of Claudin 3 and Claudin 4? They have 2 known functions in normal tissue. One is a barrier function, where they play, they seal around the cell and they serve as a physical barrier to prevent solute, and in particular water, from passing freely through, again, the paracellular space. And the second function is the fence function, where they play the role of a boundary between the apical and the basolateral plasma membrane domain to create and maintain cell polarity. This feature is lost in ovarian cancer cell, in particular in fully differentiated tumor. Now, Padmorin group at the NIH has recently shown that the overexpression of Claudin 3 and Claudin 4 is directly related to tumorigenesis of ovarian cancer. In particular, is able to increase invasion and survival of ovarian tumor cell. And they did an elegant work, again, to show this. And this data, of course, in ovarian cancer, therefore, they support the view that the overexpression of this tight junction protein is selectively modulated during the process of oncogenic transformation and play an important role, again, influencing tumor progression and invasion. Now, the real reason why my group, as well as several other now, they really start having a lot of interest around overexpression of Claudin 3, Claudin 4 in ovarian cancer, is, however, related to the fact that Claudin 3, Claudin 4 are the natural receptor for Clostridium perfringens enterotoxin, also known as CPE. CPE is a single polypeptide of about 35 kilodalton, is a relatively short protein, 300 amino acid, and is, of course, a virulent factor responsible for causing the symptom of Clostridium perfringens type A food poisoning. That is the second most common type of food poisoning in the US. Now, this cartoon describes the functional domain map of the protein. And what I'd like you to see here is that with the work of Bruce McLean, it's now clear that the receptor binding domain of the toxin is related to the carboxy terminal fragment, the last 30 amino acid, while the amino acid from 45 to 290 are really related, they encode for the large complex formation and the cytotoxicity of, again, this protein. And so the important thing is that there are at least 25 tight junction proteins that are present in our cell, but it's only Claudin 3 and Claudin 4 that are that they have the ability to bind with very high affinity against this toxin. So the most important point is that, as I'm going to show you in the next few slides, is that the toxin is able to trigger a multi-step mechanism that lead to the lysis of a mammalian target cell when they overexpress Claudin 3, Claudin 4. And this is very fast because it's related to an increase in membrane permeability that result in the loss of osmotic equilibrium inside the cell. And this is, again, peculiar against cell they overexpress Claudin 3, Claudin 4, such as ovarian cancer cell. In contrast, the majority of the cell of our body that they do not overexpress Claudin 3 or Claudin 4, or they express negligible level, they are not susceptible to cytotoxicity. Now, on the basis of the information, it's clear that CPE-mediated therapy may therefore represent a novel, potentially highly effective strategies for the treatment of ovarian cancer that is resistant to chemotherapy, as well as other biologically aggressive epithelial tumors, such as, again, prostate cancer, breast, or pancreatic cancer, where the overexpression of Claudin 3 and Claudin 4 has already been reported. Now, let me show you a little bit the follow-up data after the gene expression profiling that we've done, again, to validate the expression of Claudin 3 and Claudin 4, in ovarian cancer, in particular in chemotherapy-resistant disease, and to show you that indeed the toxin may be really effective against this tumor in vitro as well as in vivo. So this is are the result of an RT-PCR experiment again in a group of tumor from 16 to 26. These are fresh frozen ovarian tissue, different from the one that I showed you before, and where we tested again for Claudin-3 and Claudin-4 expression, the disease, and from 1 to 15 were all the control that we've used in this study, once again to evaluate the expression of Claudin-3, Claudin-4, and these were normal ovary, normal endometrial cell, normal cervical cell, fibroblast, PPL, B cell, dendritic cell, and so on. And as you can see here, again, there was a major difference in the expression of Claudin-3 and Claudin-4 in this fresh frozen tissue when compared to all the normal tissue that we have used. More importantly, when we look to chemotherapy-resistant tumor, that is really what we would like to be able to kill in vivo, we found that when we compare, once again by RT-PCR, Claudin-3 expression in chemotherapy-naive tumor versus chemotherapy-resistant tumor, and this is again, this is showing the result for Claudin-4. Once again, we found a dramatic difference in terms of expression between in the expression of Claudin-3 and Claudin-4 in chemotherapy-resistant disease when compared to naive tumor. And these are 3 patients where we were able to collect, once again, before, these are match sample, before and after the chemotherapy, again, tissue, to be able to extract, once again, RNA to evaluate for Claudin-3, Claudin-4. Now, the target is a receptor, so must be expressed on the surface. So it's not enough to look at the gene or the messenger RNA. We really need to look to the protein expression on the surface. And this is, again, a representative immunohistochemical staining of one of these chemotherapy-resistant tumor, where we look, again, to expression on the membrane, as you can see here, a strong expression of Claudin-4, the high-affinity receptor for CPE. And we also look to the coelomic epithelium of the ovary, that, as you can see here, has low to negligible expression. So does the toxin really work in vitro? Is the toxin able to kill tumor cell? This is a dose-dependent CPE-mediated cytotoxicity assay of primary ovarian cancer cell line. They were compared to our, to our positive control that are verocell, so the green monkey kidney cell where the Claudin-3, Claudin-4 gene were expressed, that are well known to overexpress a lot of Claudin-3, Claudin-4. And we compare, again, the verocell sensitivity to the one of, again, 6 primary cell line, 3 established cell line, and the group of normal control. And we use different doses of CPE, from 0.8 microgram per ml to 3.3. As you can see here, all primary cell line were highly sensitive to the exposure to CPE, and after 24-hour exposure, all the cell, 100% of the cell were dead. And this was also true for the established cell line that we bought from American Type Culture Collection. In contrast, when we look to, again, normal cervical keratinocyte, normal ovarian epithelial cell, fibroblast, so on, there was not cytotoxicity visible. And this is a visual representation to show you what happened after the exposure of the toxin on this extremely aggressive cell line. This is a typical phenotype of a serous papillary carcinoma, culture, again, in media as a monolayer. And this is the same cell line after 15 minutes of 3.3 microgram per ml of the toxin. As you can see here, all the cells are detached from the plastic. They are floating. They look like balloon because they are full of water, because as I told you before, CPE work on the cellular membrane of this tumor, changing very rapidly the permeability of the plasma membrane. And they look again, once again, as balloon, and they're dead by trap and blue exclusion. Now, when you're dealing with a toxin, you're always concerned about toxicity. It's a poison that you're using, again, to kill, in this case, chemotherapy-resistant ovarian cancer. But in the last few years, the NCI, again, sent out issue an announcement, and I think that all the medical oncology, gynecological oncologists are well aware of that, where they were recommending the administration of anti-cancer drug directly in the abdominal cavity. And why? Because there were 3 prospective randomized studies showing that the use of IP and IV chemo, when compared to the gold standard, that is still the IV chemotherapy, was able to increase survival. For us, this was very important because, of course, when we were using a toxin and we were injecting therapeutic dose of the toxin IV, we found that the toxin was too toxic. We were killing the animal. But instead, when we were injecting intraperitoneally the toxin in the abdominal cavity, the animal was able, of course, to tolerate the toxin administration. And combining this with the fact that ovarian cancer it remains confined to the peritoneal cavity for much of the natural history, make us think that an IP therapy in this specific situation could be beneficial because, of course, we could really administer high dose intensity in the abdominal cavity with minimal systemic toxicity. And let me show you what we have done to demonstrate this. So this is a typical necropsy specimen from a CB17 SCID mouse 6 weeks after the injection of one of our chemotherapy-resistant serous papillary ovarian carcinoma. As you can see here, the abdominal cavity of this animal is full of disease. All these vegetation are neoplastic. This is an omental caking. These are plaque of cancer close to the liver. They are not inside the liver by necropsy, but they are on the surface. So they really resemble very closely what we see in the abdominal cavity of our patient. So, and the goal was at this time point to try to see in an animal with large amount of tumor burden, if the toxin administration, injected IP multiple times, could really make a difference. So after 4 weeks from the injection, intraperitoneal injection, in this case of 7.5 million of this tumor cell, we started injecting every 3 to 4 days for a maximum of 10 times, different doses of CPE. In particular, we use 5 microgram total, 5.5 and 6.5. As you can see here, after 42 days, all the mice injected with the saline control were dead, while mice injected with 5, 5.5, 6.5 were increasing their survival. And this was impressive for us because, once again, we're starting injecting the toxin in animals that they had established disease for 4 weeks. So they have minimal lifespan left, of course, to be able to make a difference. And indeed, when we repeat this experiment in mice with less tumor burden, so in this case, we injected 5 million cells of the same tumor, and we started injecting the toxin. Now, a higher dose of the toxin, 7.5 and 8.5 in these 2 cohorts of animals. After now 1 week from the injection of the tumor, we found that while all tumors were dead within 60 days, 3 out of 5 on animals injected 7.5, and 5 out of 5 of the animals injected with the higher dose of the toxin, 8.5, were actually were cured for the disease, because these animals, indeed, they did not die for recurrent disease even later on. So I conclude again, and this is our summary, the primary ovarian cancer that have acquired in vivo resistant to chemotherapy may be highly susceptible to killing by CPE-mediated therapy in vitro as well as in vivo. We believe that the intraperitoneal CPE administration may have potential as a novel strategy in the near future against chemotherapy-resistant recurrent ovarian cancer, in particular in this case in patients that they are refractory to any standard treatment modality. And it's a good thing that also the NIH is supportive of this, because we are in the middle of our NIH grant R1, work funded by to really develop this therapy in my laboratory. And of course, the goal is the future design and implementation of phase 1 and phase 2 clinical trial in this group of patients. We are taking this research in new direction. We have established collaboration with different groups here at Yale. And in particular, I want only to cite that, to mention that with Dr. Saltzman in the Department of Bioengineering, we have already conjugated nanoparticle with the carboxy terminal fragment of the toxin that is not toxic at all, but is able to internalize inside the tumor cell. And therefore, we have, again, we are working with him to see if we can deliver again, a cargo inside the tumor cell using this strategy. And finally, I want to, again, acknowledge my lab people, in particular, Dr. Emiliano Cocco, Dr. Stefania Bellone, Joyce Varughese, that is our first-year gyn-onc fellow training in my laboratory, Marta Bellone, Paola Todeschini, and Luisa Carrara, that is a resident, Italian resident, spending 1 year with me here. Thank you very much.